Looks like we are about set. And so welcome everybody to our webinar on health center partnerships for health professions, education and training development. I am Alex Rolling with the STAR Center, and I hope everyone's having an excellent week. We are going to go ahead and get started. So, like I said, we are here on behalf of ACU, the Association of Clinicians for the Underserved, and ACU was started, I think, over 25 years ago now at this point, by alumni from the National Health Service Corps, and basically exists to help health centers and PCAs with workforce recruitment and retention, and basically everything they need to make sure that there are staff in their health centers to help serve the underserved populations they work with. And then as part of ACU's programming, we have the STAR Center, which is the Solutions and Training. Sorry, my slides messed up here. There we go. But anyway, the STAR Center, which is our NTAP, we work through a HRSA grant, and we specifically are focused on recruitment and retention for the workforce. And for any health centers and PCAs, everything we produce is free, and it's available at our website there, chcworkforce.org. And of course, if you have any questions, please feel free to contact us at info@chcworkforce.org. And with us today, we have almost the entire STAR Center team. And Mariah is working behind the scenes here for technical assistance. So if anyone has any issues today during the webinar, please go ahead and send her a message either in the Zoom chat, or you can email her at mblake@clinicians.org if you're having any technical issues today. All right, now I am really excited to introduce our three speakers. With us today, we have Dr. Kiki Nocella, who is the director and practice leader of Wipfli's Clinical Operations Consulting Practice. She provides clinical operations and graduate medical education consulting services for Wipfli. She leverages her vast experience in the healthcare industry to provide top-notch consulting services to hospitals, federally qualified health centers, consortiums, and academic health centers. Her areas of focus include medical education, strategy, and program development. She also focuses on medical education financing, strategic planning, urban and rural underserved populations, provider relations, and population health. With us today, we also have Dr. Sharon Obadia, who is the interim dean and associate professor of internal medicine at A.T. Still University School of Osteopathic Medicine in Arizona. Dr. Obadia previously served as ATSU SOMA's Associate Dean for Clinical Education and Services, in which her primary role was to foster strong and enduring partnerships with its National Association of Community Health Centers, partnership sites throughout the United States. Dr. Obadia has also served as chair of the Clinical Sciences Education Department and director of faculty development at ATSU SOMA. And then we also have with us Dr. April Dobroth, who brings 20 years of teaching experience to the role of clinical director at Frontier Nursing University. For the past 9 years, she has served in rural and underserved communities as National Health Service Corps member and ambassador. As a healthcare provider, she demonstrates a strong desire to promote care delivery in underserved communities. And Dr. Dobroth has worked closely with several members of the New Mexico State Legislature to develop strategies designed to increase the numbers of healthcare providers in rural areas in New Mexico. Oh, and when she is not teaching, Dr. Dobroth also enjoys spending time with her husband, 3 children, and 2 dogs. All right, and now we're going to do a quick Menthometer. I think any of you that have joined us in the past know how Menthometer works, because we use it pretty frequently. But you can take out either a smartphone and scan the QR code that's on the screen, or you can go to menti.com and enter the code 6246570. And I'm going to put that into the chat here real quick. And that will take you to the Menthometer quiz. I'll give everyone a second here to get that information down, and then I will switch to the Menthometer screen. And the first question is going to be a summertime question, because it's really, I'm here in Florida, so it's really warm out. We were just discussing the weather earlier. And so it's, what's the hottest planet in the solar system? And no cheating by Googling it. Just try to answer it based on what you know. All right, let me bring that up here. Okay, so we've already got a bunch of answers in. Excellent. All right, good. Only one person thinks that Tatooine is in our solar system. That's from Star Wars. So it's a long time ago in a galaxy far away. So unfortunately, it's not Tatooine. Let's see, we got a bunch of votes for Venus. We have Jupiter, Mercury, and one for Earth. Sometimes it feels like Earth is the warmest in our solar system. I guess we're kind of heading that way, but we're not there yet. All right. So the hottest one is Venus. It has a surface temperature of something above 800 degrees Fahrenheit, which is warm enough to either melt lead or burn a Stouffer's lasagna. All right. And then these are just free response questions. If you're up for it, if you could enter the organization that you work with, your role at that organization, and your time in that position, just so we can get a feel for everyone that's here today. Oh, there we go. All right, so we have, thank you, Kelly, with Wipfli's GME and workforce team. We have someone from the Kentucky PCA, workforce program manager, has been there for 2 years. We have a director of workforce, almost 2 years, director of operations, 6 years. Let's see, Westside Family Health HR director, about 1 year. CHAMPS program coordinator, health center workforce, about 8 months. Me PCA. Let's see, we had a couple people put in the chat, Bi-State Primary Care Association project coordinator for 10 months. We have Lisa Weaver with us, Chief Strategy Officer of Boston Mountain Rural Health Center. And she's been in that role 2 months, but previously 22 years with a PCA. And let's see, Association for Utah Community Health, we have program specialist. So we have a whole range of people here today. That is excellent. Okay, well, that's really great to see that whole range. I know a lot of people are new to their positions, and then we have a lot of veterans or some people that are in a new role but have been in the health center world for quite a while. So that is really excellent to see. All right, and then our final Menthometer, what do you want to learn most from today's webinar? And hopefully it's not just which planet is the hottest in the solar system. Because most people knew the right answer, so. Okay, well, oh, there we go. I was just about to abandon hope of any response to this one. So recruitment and retention ideas, as much as I can, trying to serve as much knowledge as possible. There's a new area. Roadmap to follow to build career pathways. All right, excellent. Well, I think, oh, and we've got in the chat, inform our state level effort for development of academic partnerships and enhancing center experience. Excellent. So I think everyone here is going to get a lot out of this. Let me go back to this. Oh. Interesting. I apologize. My screen share went away. There we go. Okay. So I think everyone's going to get a lot out of this presentation today. And now I'm going to turn it over to Kiki. And she is going to talk about finding and sustaining healthy partnerships.
Great. Now you need to stop sharing, right? Okay,
Yes.
great. So I can
now
share.
You should be able to share.
Yay, there we go. And I'm going to need to minimize this and make this big. Yeah, that's not what I want. Sorry. I'm looking, how do I get there? I need this to disappear.
Oh, just down at the very bottom there. The little, it's right next to the sizing scroll.
Yeah, it's blocked right now because of the, wait, there we go. Let's do this. Now we got it. And I will move this. Okay, great. So I am here to talk about finding and sustaining healthy health center, academic, health center, hospital partnerships. Something that folks deal with all the time, every day. And they're challenging. They're challenging. So first, let's start with why. Why are we even going to worry about these partnerships? You know, health centers over the history of their existence went from a model that was very heavily university oriented and also hospital oriented, where you would do much more inpatient work, to becoming much more isolated, and in fact having some pretty strong negative views towards academia, to now being back in a place of looking at partnerships again and developing partnerships again. And there are many reasons for that. Part of it is when it comes to workforce, our accrediting bodies require it. You know, I'm going to talk a lot about workforce from the perspective of physicians, but you know, even if we want to talk about dental residency programs or other residency programs, or other clinical workforce programs, there's still often a hospital component in it. So accreditation is one reason. Another reason is folks realize that in order to address the community health needs in their community, it takes a village, and each entity brings their unique strengths and perspectives. They also bring their unique resources, and they bring, of course, some baggage as well. And that's part of what we've got to talk through, is understanding what they bring to the table, both good and bad, and how to deal with that. And finally, when you've got these different entities all working together, there's a diversity of thinking, which is hugely valuable. So, and I don't know if you guys see these boxes, I'm going to move that. Not to pick on our academic institutions, but they are often viewed by community as the 800-pound gorilla. You know, wielding its size, its power. Sometimes it's state commission. They're state commissioned, and that carries an awful lot of weight to get what they want in community. Okay, and whether it's true or not, it doesn't matter, because the perception is still there by community members, by health centers, by hospitals. As I shared, health centers often don't have relationships with their hospitals. It is the norm when I go into a health center and I ask if any of their physicians, if any of their providers have privileges at their local hospital. It's the norm that I hear no, they do not carry privileges. Okay, and so because of that, there's really not a lot of relationship there other than referral patterns. On the flip side, there is a very strong movement that's been going on for the last couple of years of hospitals thinking that they can create their own health center as a solution to their primary care objectives, okay? And I put their own in quotes because I know what you know. They can't just create their own, but they've come up with lots of great arm's length ways of doing so. You guys haven't lived in each other's shoes, so you don't necessarily understand each other's perspectives, all right? So I like to put the conversation of partnerships in terms of the life cycle of dating and marriage and all that goes with that. Because really what we're talking about is a marriage. And if for no other reason we're talking about it as a marriage, it's because we've got learners to protect, okay? And so it is a long-term relationship you are building. So this first slide's a little strange. It takes some explanation. I have a 18-year-old and a 22-year-old, both girls. And when I first did this presentation, I said to my youngest, so she was in high school, so when you and your girlfriends are talking about, you know, a guy that they like or are interested in or crushing on, what do you say? And my daughter said to me, oh, well, we'll use a code word for the guy. And whenever we see him, we'll call him by that code word to each other. And, you know, let's just say the code word's pineapple. Hey, pineapple likes you. Or, oh, there goes pineapple. And do I look cute? You know, always want to look cute and have your makeup done or whatever it is. And then wondering, are they going to ask me to the prom or to the formal, right? It's a very young, naive, glassy-eyed approach to relationships. And we see that when health centers who have not had relationships with academic institutions start that process. Also, I'd say we have it to a lesser extent, but we also have it when health centers start that process with hospitals. Okay, but with academia, we take an approach of, well, they want to partner with us. Oh my gosh, I'm so lucky that XYZ academic institution wants to partner with us. And all of that is very naive and very glassy-eyed. Okay? From there, with that, I'm gonna go back a little bit. With that glassy-eyed naivete, it's really important to know your value. Okay? And that's one message I give health center to health center to health center is know your value. So for example, your value to an academic institution is your patients, because patients equal curriculum. There's a report put out a number of years ago by a national nursing organization, forgive me for not remembering which one, but it talked about in all areas of medical education, the need for clinical rotations and how the bulk of capacity for clinical rotations have been taken up in hospitals and other settings. And the last big hope for clinical rotations was in the health center arena, which is part of why you're getting contacted all the time for rotations. It's because health profession schools have done nothing but grow, which means more learners, which means more need for clinical rotations, which means your patients, okay? That's hugely valuable to them. There's your NAP, your NAP grants and your you know, and the opportunity to partner with you to create a new site that gets funding from HRSA in order to stand it up. That's a much more financially viable option to a hospital or an academic institution than just going out and setting up their own clinic. Access to FTCA, if structured right, is always valuable. Your payments, you know, your reimbursement. And it's important to be really clear with the other entities that it is your reimbursement. Years ago, I had a major consulting firm say to me that it would pass through to the medical school. And I'm like, no, it won't. It will offset their costs of training as long as the costs are the health center costs, but it doesn't just pass through to the other entity. You know, so you see the list, you have huge value that these other entities may not have, and therefore that's why they want to partner with you. Know your value, don't be glassy-eyed. and know that you matter, okay? But you putting yourself out there, it's about keeping an open mind, keeping yourself safe, setting your own pace, and remembering that this takes time. And I think you guys can see this down here. I'm not sure, but it's rules for dating, right? We would all say this to our daughters and to our sons. It's knowing that you matter and keeping yourself protected in the process, okay? To that end, let me focus a little bit on university partnerships, and Dr. Sharon Obadia will be coming on right after me. So I think the world of her. And so I look forward to her saying, no, it's not going to be that way with us. But in general, academics are groomed to become experts on a grain of sand on the head of a pin. Okay. You learn to focus very, very specifically on a very teeny tiny issue. And that becomes your research. And you are an expert in that grain of sand. Well, because of that, if you approach me as a faculty member with what you think is a phenomenal idea, I'm looking at it going, yeah, it doesn't fit my grain of sand, doesn't fit my research. And so you have to go person by person. And if you're lucky, you find the person who shares the same interest as you do. That's why it takes time, okay? So let's jump to engagement. You've been dating a little bit, you've kept yourself safe, how do you know when you're ready to get engaged? How do you know if this academic institution is the right one for you, or this hospital is the right one to partner with? Well, it's the same rules as what eHarmony tells us as the rules for engagement. You both have full lives, right? You don't need the hospital, you want the hospital. You don't need the academic institution, you want it. But more importantly, you share similar values. You would elope, okay? You're ready, you know it. You don't need some big ceremony. You would go elope. You don't have cold feet, and everything can be talked about. It's transparent, okay? And you're done searching, right? Because you bring out the best in each other. You see the value is exponential of the two of you bringing your ideas, your resources, your talent together. So you heard me say a minute ago, transparency. That is, to me, one of the most important pieces, okay? Is that when it comes to financials, you're transparent. When it comes to operational challenges, you're transparent. There are, of course, legal rules around transparency. I'm not going to dive into that, nor am I a lawyer, but you want to have lawyers anytime you're involved in formalizing this engagement, right? But the process of becoming engaged allows you to get to know more about each other, your scopes of services, your strategic objectives. I like setting up a joint operating committee. And I call for, if everybody agrees, regular true-ups of the financials, so everybody knows what's going on. And I already see a typo, but you educate them on your HRSA and IHS requirements if you're an IHS entity. All right. I believe in a prenup. Now, I didn't when I was 22 years old and getting married, but when I went through a divorce, I sure wish I had one, right? In your prenup, you are planning for the unwind of this relationship. And again, it's not because you want it to unwind, but because you're practical and because there are learners involved and you don't want their lives unwinding because you guys can't get along. Okay, you can't make it work anymore. So you work out the typical things about an unwind. For example, in a residency program, is there a right of first refusal? If you don't want it, can I take it? Working out things like that. I believe in long termination clauses because, once again, it's about the learners. Who gets the kids, right? What happens to them if this relationship, to the learners, if this relationship unwinds? Then you get to the marriage. And the marriage is about, again, we all know what the rules are, right? It's the implementation, it's the work that gets a little harder, but it's communication. It's that transparency again. Issue raising, not letting things fester, okay? Respecting each other's strategic objectives and business needs, right? Jointly making decisions through that joint operating committee, and having and renewing your joint vision. Just made me think of a new slide. I have to have marriage renewal in here. Okay, I've mentioned the kids, the learners, okay? There's no such thing as an oops. You got into this relationship so you could have learners, right? And so you need to be a strong family. You need to eat dinner together, right? Partners together involved with these learners. The hospital CEO, your residents should know who that is. They should have met with him or her, just like they should have met with the CEO of this health center and the chair of the department that they're in for the academic institution. These folks need to know each other, and it provides structure. Each entity has its own that they provide. The academic institution has libraries and faculty development and scholarly activity that they can provide structure for, as an example. I have lots of terms of agreements, terms for your agreements that I like to see in here. I'm not going to go through it. We don't have the time. But this is some of the list. I said I like long terminations. I like long contracts. I like the prenup, the wind down provisions. And things like agreed upon financial tools up front. So people can't go a year or two later and go, oh, but I forgot, and then skew the entire financials, right? Also, there's business points that need to be additional business points that we need to look at. In the health center, the hospital and the academic institution need to understand that there is an impact on your clinic sites, both financial and in the scheduling of patients. It is not uncommon for a residency program to suddenly have a learner, a resident's experience be switched at the last minute. Well, what's the impact to your schedule if suddenly they're pulled off clinic? That can't happen, and there needs to be consequences to something like that happening. Currently, you as a health center need to understand things about program evaluation and resident evaluation and faculty development. So there's lots of stuff to work out up front. There's also this concept with most medical schools of tithing or taxes. It comes by different phrases, but there's an upcharge in your financial relationship with a medical school. And again, it varies. I'm currently doing one school of medicine that charges an additional $80,000 per head of any faculty member you lease. Now it doesn't take long to figure out that becomes cost prohibitive. Okay. What have you seen work? What have you seen not work? I think for interest of time, I'm gonna not go through all of that, but for your own thinking or benefit, think about some of the things you've seen not work and how you would do it differently. And with that, I'll pause because I think I am probably over time, if not right at time.
Excellent. Thank you, Kiki. And now we'll turn it over to Sharon from AT Still University.
Thank you, Alex. And thanks everyone for having me here today. I'm very happy to be here talking about something I absolutely love to talk about, which is our AT Still University School of Osteopathic Medicine in Arizona's partnership with the National Association of Community Health Centers with our partner sites around the country, and how we develop workforce for these community health centers around the country with this program. So I'm a general internal medicine physician and our interim dean at ATSU SOMA. And I wanted to start my slides with this picture because it represents so many of the amazing things that happen at all of our sites around the country. So to give you a little bit of history, AT Still University is the founding school of osteopathic medicine And in 2006, AT Still School of Osteopathic Medicine in Arizona was started, and it was founded on a mandate from NAC. NAC asked AT Still University, would we have partnered with you for a dental school? And we would like to do the same for a medical school, because we would like to embed students in our community health centers to early in their medical education, to give them a sense of comfort and muscle memory for working in a community health center, so that when they are finished with residency and are deciding where to practice, there is greater likelihood of them choosing to come back to our CHC or another CHC and continue their work in an underserved community. So these are our partner sites around the country. We span from Hawaii to South Carolina, Brooklyn, Chicago, Seattle. We're basically throughout the country. We have 16 sites, and I'm going to explain some of the challenges and some of the huge benefits of partnering with community health centers. And so we use this as a workforce development tool, but there are some, as Kiki was mentioning, some steps that you really need to make sure which site would make a great partner. And it is a trust-based relationship. We need to make sure that each of our partners is on the same page as us with regard to the amount of intense involvement it takes to take on a student cohort, if you will, to usher them through their training at a site. So at our school, we have our students for the first year, they're on the Mesa, Arizona campus, where I'm at right now. They spend their first year doing the basic medical school didactics and hands-on skills, including their osteopathic manipulative medicine skills and their clinical skills as far as physical exam, diagnostic skills. They do anatomy in small groups. Then when they go out to second year, they are assigned at one of our partner sites. They physically move to that site. And at every site, we have physician leaders who are called regional directors of medical education and osteopathic faculty. So these regional directors of medical education are physicians that the CHC has identified to be some of their top teaching physicians at the CHC, who can basically mentor each site. I've got this on a timer. Each site takes 10 students per year, approximately 10 students per year. So they've got 10 second years, 10 third years, and 10 fourth year students. And these physicians oversee them at the site and are their mentors. It's the second year is comprised of a basic schedule that is very similar to the first year, but the main difference is in this green section called the clinical experience. So 1 day per week, the students are in the CHC with physician mentors and seeing patients with the attending physicians. They're not shadowing. They're actually been trained to be able to go in and take a history and do a physical. And one of the challenges we do have is making sure that that CHC is large enough in order to have enough clinical preceptors for these students. So that's you may say, oh, that's easy. One student once a week for 8 hours. You would be surprised how challenging that can be for a smaller CHC, even for a larger CHC that has been affected by workforce difficulties throughout COVID, for instance. This has been a uniquely challenging time for us. So then they also have their classroom physical exam and osteopathic manipulative medicine skills. Each of our community health center partner sites has a dedicated space. That's another stipulation that we need, is a dedicated classroom for the students. This, for instance, what you're seeing now is based at Health Point in Renton, Washington, and the students have a classroom there in which it's basically their room at the CHC administrative building. These are some other of our classrooms in Tucson at El Rio CHC and Chicago and Visalia, California. And basically, there's got to be enough space for students to be able to be there dedicated pretty much every day of the week, because when they're not in class, they'll use that as a study space too. So then we talked a little bit about the clinical experience, the 8 hours a week for second year students. And then the students are also giving back to the community that they're embedded in by doing required projects. Their second year, they do a required research project that's based on a community health center needs assessment. And they determine what is needed in that community and that they can make an impact on. So for instance, this is our Hawaiian Coast Comprehensive Health Services Center in Hawaii. The students created a mini doc program and a community garden with students at the local elementary school to teach about nutrition by growing their own vegetables. So this is one example. Then they present these finished projects at the National Association of Community Health Centers annual conference. Our students are engaged together in grand rounds where they bring together where we bring together all of the students once a month. This also engages the CHC community with speakers that they bring in to present to the students. It's a great time for CHC leadership to come in and discuss, working and recruiting in a CHC and what would that look like for a student to work there when they're finished. I like to use the grand rounds as a recruitment tool whenever possible, because the students, you may say they're embedded there and it's a no-brainer for them. Oh, wow, this is my CHC, but the students they're not at the point in their development where they can picture themselves working somewhere yet. And they would, a lot of times they don't even think that the CHC would think them worthy enough to work with them side by side with their esteemed attending. So the more we can message that to the students, the better. The students are also engaged in national health policy. You can see them advocating with the Surgeon General and in health policy throughout the country and in DC for community needs, as well as needs such as the National Health Service Corps funding. One of the biggest challenges, Kiki talked a lot about this already, is that our students need clinical rotations, especially their third and fourth year, basically all clinical rotations. And our accrediting body for our medical school and all medical schools requires them to have a certain amount of inpatient experiences, and that means hospital affiliations. And this can be a very challenging aspect of the partnership, because the CHC does need to have those connections in the community with partners, hospitals that are willing to have students. That can be extremely challenging and costly. The clinical rotation fees are skyrocketing and not going away. And so it's a challenge. So anybody thinking about partnering with medical students and PA students who also need 2 inpatient clinical rotations in the form of surgery and emergency medicine, this is something that you've got to really keep an eye on. Can we sustain that for these students? Because if we can't, we do have to send the students somewhere for those rotations, and that can be costly with travel and housing. So that is something I really want to enforce, that when you're thinking about partnering with a medical academic institution with students, that they do need rotations that are outside the scope of the CHC itself. The CHC itself actually can have a difficult time having enough physician preceptors to teach the students when I'm talking about those month-long rotations for third and fourth years. So that's probably one of the biggest challenges we face. And larger CHCs, if that makes sense, does do better. And so we try to look for partners that have, at least 60,000 lives served. We do have a couple partners that are smaller, and that can be very challenging. Consistency is very key. We need to make sure with our accrediting body that our students are getting a very consistent education across our partner sites around the country, that one site is not scoring below all the other sites on boards or with their teaching and didactics. So it's something that partners really have to keep an eye on. We do this by ensuring that all of our materials are consistent across the board from our Mesa campus, as far as syllabi and learning materials, graded assignments. We even review student case logs of the patients they see around the country to make sure that that is quite consistent across sites. We have studied this, and we are proud to say that we've never had a statistically significant difference in performance across all of our sites throughout all of these years. Our first graduating class was in 2011, by the way. So we also ensure that we review our student evaluations of rotations to make sure that each site has robust clinical rotations. And we review the rotation, the attending physician's comments about our students so that we're not seeing, you know, something dipping at one of our sites. If that were to happen, we would make a concerted effort to do a quality improvement assessment to determine what is needed at that site. Maybe it's an RDME switch. We have not had to do that, but it is something we keep in mind all the time. Kiki noted this too in her slides as far as staying connected. And so we meet constantly with our CHC partners, administrators, the regional directors of medical education, site visits, advisee site visits. We have chairs of our regional directors of medical education. We meet quarterly. And so it's all about keeping that strong connection going forward so that we can face any challenges very quickly and also celebrate all of the wonderful things that happen. We do have graduates returning to our CHC partners as attending physicians, and this is the best part of my job when we see that it's working and coming full circle. One of the biggest full circle moments is when we have somebody we call a hometown scholar who was picked from that community health center, and we call this the ATSU hometown scholars. The community health centers will identify, maybe it's somebody who was a medical assistant at their site who always wanted to be a physician. They write a letter for that person. The person is looked at very closely by our admissions committee. They, if accepted, they go right back to that site for their second through fourth year. And then at quite a few of our sites now have residency programs, teaching health center residency programs. And when we've had students stay at those programs and then come back to be an attending at that CHC, that's the proudest moment we can be. And that is full circle with hometown scholars. I'm going to leave it at that, Alex, and stop my share so that we have plenty of time for April. And thank you very much.
Okay, thank you so much, Sharon. That was excellent. And yeah, now we will move on to April.
So much. I think I need you to go ahead and stop sharing.
Got it. Thanks.
Thank you so much. That was a great presentation. Really appreciate it. So today I would like to focus particularly on mental health. Can you all see that slide?
Yes, yeah.
Perfect.
There.
Okay. So today I really, my biggest passion as a care provider is really the provision of mental health services to those communities in high need. While we know there's a huge need post-COVID across the nation, our rural and underserved communities are really suffering greatly from that lack of care. So today I'd like to talk about some specific strategies to address that and how do we retain those key specialists in the areas of need. So a few different objectives today that I'd like to focus on. I want to address some of the practice-based gaps that we see in that provision of care. I also want to talk about some strategies to really focus on increasing psychiatric professionals and bringing those professionals and keeping them in those underserved communities. I'd also like to introduce briefly some particularly innovative strategies that have been found to really bring mental health services to those communities and community-based organizations. And I'd also like to address the high need for increased diversity, particularly in these areas. So a few of the practice-based gaps that we see. We know the prevalence of mental health is very high across the board. This statistic, 1 in 5 adults, was really prior to COVID. I would venture to say that's much higher. And I myself, working primarily in a pediatric psychiatric role, we're seeing a huge increase in need within that particular population during and since COVID. 85% of our health professional shortage areas are in rural areas. And these particular areas have a great challenge in securing psychiatric professionals. And we know that 65% of people in those areas, those rural area, underserved areas, do not have access to psychiatric services. So the need is quite pronounced. Sadly, we know that 55%, we know that suicide is 55% higher in rural areas. In my own community in southwestern Colorado, this was featured in both the New York Times and the Washington Post. We had the highest rate of suicide amongst women ages 35 to 65. It was really pretty alarming. Many, and this is a particular concern. We know that 40% of Americans identify as an ethnic group other than Caucasian. This is projected to increase over the next 10 years fairly dramatically, but yet fewer than 15% of our mental health service providers fall into this category. I do not have exact figures for psychiatric professionals, but I would venture to say that that's quite low. We are really missing the mark in serving those populations. Some particularly alarming statistics that we see amongst the Native American teens and adolescents in particular, their suicide rate is double that of Caucasians. And I work with a lot of Native American groups in the area in which I live, and we see a very high prevalence in that population. Suicide is the second leading cause of death for African American males ages 15 to 24. And 42% of our high school students here in Colorado, where I reside, who identify as LGBT, have reported that they seriously considered suicide in the past year. These are pretty dim statistics, but I just wanted to share them because the need is so very great. Now, how do we work with this? So some strategies to really improve that access to care. Many of us are familiar with the integration of mental health services into primary care. It's very important to really explore those particular strategies that work and those that work well based on evidence-based practice. Oftentimes we see attempts to integrate these services into primary care, but they fall short in meeting those needs. So there's some key components that need to be addressed within that area. Partnerships with academic institutions, we're touching on that quite a bit today. I was really thrilled to hear about some of the innovative work that you're doing, Sharon. I think that's wonderful and really tying students to those communities, because that relationship is key in how do we keep those providers and particularly specialists out there. Another thing I wanted to touch base on is how do we bring those services to the people where they need it? One way that we can really be successful in retaining those specialists in particular is connecting them to the communities. We do know that specialists such as psychiatrists that come to rural areas, when they feel a connection with that community, they're much more likely to stay. And that's a key driver. And finally, how do we really not only secure, but retain those psychiatric professionals? So a few different outlooks on how do we bring integrated care and those models of care to areas in need. I want to share with you one particularly successful integrative model of care. Patients were involved with a particular health service organization, a federally qualified health center. There was a relationship that was established not only with the sheriff's department, but the local hospital and ER to really focus on those patients in crisis when they needed that care. And a crisis hotline was established. Each of that number and contact information for the crisis hotline was disseminated through law enforcement, through hospital staffs. So literally nurses, anyone that received that call as the patient entered that crisis environment, they could be diverted to this crisis facility. Once the crisis hotline received that information, the patient could be brought within 24 hours into the clinic environment. They would then be seen by a primary care provider within 48 hours. Now, here's the key component that helped this model of care to really be viable. Psychiatric consult was always available to those PCPs. This actually ended up decreasing psychiatric workload significantly because that consult could happen initially And then patient follow-up could happen, say 3 months later, versus the patient waiting 3 months for care. Because what was happening in this particular community, patients would end up in the ER, be on the observation deck, and really not be able to receive ongoing psychiatric care. So that follow-up happened, and that was really key. The patient could then be provided with all kinds of community resources, counseling, primary care, psychiatric care. So that true medical home model of care. Some of the results that we saw from this implementation of this model of care, patient satisfaction scores for the FQHC for patients involved in this particular model improved from 72% to 98% in a very short period of time. This is about 6 weeks. There was a reduction, an estimated reduction in per capita cost of care of $653,000. And this was really represented by the cost of care in those patients arriving at the emergency room door. They would typically remain in observation in the ER, and per day, the cost was very significant, but the average cost for those patients entering the ER with a primary diagnosis of a psychiatric condition was about a little over $14,000. So those patients that were diverted from the ER in that 6-week period of time really represented a significant cost savings for the community. And most importantly, this also decreased the workload of our psychiatric professionals significantly, and they reported greater job satisfaction as well. Partnering with academic institutions. Through the Frontier Nursing University, I am involved in the establishment of a behavioral health workforce educational training grant through HRSA. This is really designed to increase the number of psychiatric mental health nurse practitioners in those key underserved areas. Our other key focus is to increase diversity of psychiatric professionals that are going out to these underserved communities and really providing that critical care where it's needed. This involves the collaboration with clinical partnerships across the country. I'm happy to say we have been able to establish relationships West Coast to East Coast. Part of the educational program at Frontier Nursing University involves a system of regional clinical faculty members who work in specific regions. They have established relationships with all kinds of clinic, hospital systems, and providers. And they actually go to the clinical sites several times to not only work with the preceptor in this case, but also the student, and really put those boots on the ground to provide that relationship and follow-up. Some of our special focus areas within this grant program is really to focus on that high need that I highlighted in the pediatric and adolescent population, where we have those high risks for suicide, particularly in the diverse population. When I mentioned those staggering statistics regarding Native American youth and also African American males, adolescent males, we really want to target that high need. And really also a focus on targeting the need for intimate partner and youth violence. Suffice to say, youth violence is on the rise, and I do not foresee that that problem will improve anytime very soon. So we really need to provide that care for those populations. Experiential clinical partnership training sites receive several benefits through this program. There's a mechanism of streamlined placement of our students at these sites. There's an ongoing support not only for our clinical partners at the systems level, but also preceptors and students throughout the experiential learning process. It also provides a great pipeline for potential recruitment in those underserved areas. And because the student has the opportunity to spend time in that community, to get to know the community, to form those partnerships and support systems, they're much more likely to stay for a longer period of time. We also help those sites to bring in a more diverse and culturally proficient workforce. And our scholarship recipients receive several benefits. Through the grant program, they receive support, which is extremely valuable to really help support them in going to those underserved areas. We have many students that are passionate about working in these areas, but due to the financial constraints, it's very difficult for them to go there and stay there. So this helps to provide for housing and living expenses and really breaks down those financial barriers for students. It also provides ongoing training for our students and also clinical partners. And they also receive a scholarship to the Frontier Nursing University Diversity Impact Conference, which I'm gonna go ahead and give a warm invitation to you all. We've got a very special conference going on this year, and we're very fortunate. We're going to be hosting the filming of the Apart documentary, which focuses on women that have been incarcerated and really the effects upon their family and really their re-entry into the workforce and into their communities. So, and we'll also have the participants in that film actually serving on a panel discussion. So that's going to be exciting. Now, bringing services to the people. When I talked about community support, one of the key things in really helping providers to feel connected to those communities is really developing that support mechanism within those communities. These are some particularly innovative programs that I've found and worked with personally that you may or may not be aware of. The Trevor Project provides some amazing resources for LGBT youth in particular, and they have availability to and access to a counselor and even text capability 24 hours a day, 7 days a week. So that's a great resource out there. Sips of Hope is a great example of a community-based partnership with not only providers, but clinic systems in providing that mental health services. And it really helped to identify the coffee shop as really the place where people gathered within this rural community. And I see that quite a bit in the communities that I've worked with in Kentucky. The local coffee shop can really be a center to provide that mental health education and really to connect providers also with the community and providing educational outreach and bringing those patients in. Barbershop Confessions is a great project. It's really focused on African-American males, and it actually brings mental health education to the barbershop in the community. And this is something that's gone national. It's wonderful and really helps to bring those services to that particular population where they're most likely to be receptive to that. Also, the iStory Studio is a program focused on Native American youth, and it provides a whole series of graphic novels and educational tools and partners with providers in underserved areas to really focus on the Native American youth. One particular innovative strategy that I wanted to highlight, the Colorado Coalition for the Homeless has done some amazing work to really bring services to the people. They have several programs for Native Americans and talking circles in particular. They have a WAGES group in particular, which focuses on reentry programs from individuals that have been incarcerated and provides mental health services in particular. And they also have a phenomenal mobile mental health service that not only focuses on homeless populations, but really brings mental health services and psychiatric services in particular to those communities in need. Few other staggering statistics, but we do need to consider this with regards to our workforce and future mental health professionals in particular. Frontline workers have really been hit hard through the COVID crisis. I myself worked with on the Navajo reservation with Doctors Without Borders, and the impact was just tremendous. I can't even begin to tell you. We have lost over 500,000 workers, healthcare workers, since 2020. And a recent survey showed that as many as 47% of our healthcare workers plan to leave their position in 2025, which really brings the urgency of how do we retain these key professionals. innovative strategies to really retain these professionals. Several key components have been identified to a workplace that helps to promote retention. Really having strong communication in place in that social support network, particularly for mental health workers who are hearing, are hearing some pretty traumatic stories with regards to COVID in communities, things that are happening in our society right now. They feel that secondary trauma. So it's particularly important to provide those services to them. Simple things like providing a dedicated quiet space where people can, take 10 minutes to just do some mindfulness. Adequate time off for providers. Research has found that that's a key component of how do we keep these providers on board. If we don't do that, they will leave. They will go somewhere else. Adequate time for rest and breaks. And also a really key component that research has found helps to retain those workers is providing quality health insurance with little or no out-of-pocket costs for mental health services in particular. And really promoting our specialists and our mental health frontline workers to reach out, to feel comfortable in obtaining those supportive services. So that is the finish of my presentation. Thank you so much.
Thank you so much, April. That was fantastic. We'd now like to open it up. We are technically a little over time, so I understand if anyone needs to leave. But I think April and Sharon said they have a couple minutes. If anyone has any questions, you can put them into the chat and we'll try to address them. And then obviously you can reach out to us at the STAR Center with any further questions, and we'll try to help you out. But if anyone has anything they want to put in the chat in the next couple minutes. And while we're waiting for questions to come in, the slideshow and the webinar recording will be made available to everyone. Oh yes, thank you, Mariah. Sorry, I always forget that. But we will, a little evaluation is going to pop up on your Zoom screen. If you can fill that out, that's really helpful to us with our HRSA deliverables. And then, like I said, if you have any questions, put them into the chat. We'll make the webinar recording available. And the STAR Center, of course, has plenty of resources to help folks out. Okay, so we have a question from Daniel. What are the first steps for PCAs to engage, to connect health centers, in our state to your programs or resources? So I guess what's an easy way for PCAs to connect with you to either kind of share information or to get supportive if they're looking to try to implement similar programs?
I would say in my program in particular with the BWET grant program, the best way would be to reach out to me directly.
Yeah, the same here for us. A great starting point. I'll add too that it, just as Kiki said, it takes time. The time from talking to a community health center to starting second years being there is about, I would say about 3 years of planning and relationship building.
Yeah. Yeah, absolutely. So remember that to budget in that time frame and the patience with putting all that together. All right. Well, I don't see any more questions. So real quick, I'm going to plug ACU's conference. If you want more of this, please join us in July 31st to August 3rd in Washington, D.C. for the conference. And I believe there's also going to be a digital version available because I know not everyone is able to travel. But if you can be there in person, we would love to see you all. And then I just want to thank Kiki Nocella and April Dobroth and Sharon Obadia for joining us today. Thank you so much. That was really fantastic. We really appreciate it.
Thanks for having me.
All right. All
Take
right. Thank you, everyone.